friends, my name is Aman porwal and today we will learn about jaundice, also known as Icterus. First of all, the definition of jaundice. Jaundice is defined as yellowish discoloration of skin and mucous membrane due to increase in the level of bile pigments or bile salts. First of all, now we will understand what are the basic components in the jaundice so that you can understand it properly. Bilirubin. Bilirubin is a byproduct of breakdown of heme and non-heme compounds. Heme compounds are those which are formed by the hemolysis of the RBC. During the breakdown of the RBC, it divides into heme and protoporphyrin. So, heme undergoes further metabolism to form bilirubin. Non-heme compounds include myoglobin, which further helps in the synthesis of bilirubin. But the thing is that the bilirubin synthesis from the heme is more like 90%, about 90% of the total bilirubin, while non-heme compounds contributes very low amount of bilirubin. The normal value of bilirubin is 1 to 1.3 gram per deciliter. It is further divided into unconjugated and conjugated bilirubin. Unconjugated bilirubin is also known as indirect bilirubin, whose normal range is 0.2 gram per deciliter to 0.9 gram per deciliter. In case of conjugated or direct bilirubin, its normal range is 0 to 0.3 gram per deciliter. The term direct and indirect is due to a Vandenberg reaction which you have studied in the physiology. Now we will understand the pathway of bilirubin synthesis and metabolism. So here you can see that the erythrocyte when it divides or when it hemolyzes, it forms heme and protoporphyrin. Heme undergoes further step of metabolism by heme oxidase to form biliverdin, which is converts into bilirubin. Bilirubin combines with albumin to form albumin-bilirubin complex. Now I will move few slides ahead to help you understand it properly. So here, as you can see, that the bilirubin combines with albumin to form bilirubin-albumin complex, which is reversible and non-covalent. It is taken by the hepatocytes and Some say it is by OATP, but in majority of books it is written by passive diffusion. When bilirubin-albumin splits, albumin returns back to the blood and bilirubin enters the hepatocyte. Bilirubin undergoes a major transformation in the hepatocyte by the enzyme known as glutathione transferase or UDP glucuronide transferase, in which there is a combination of glucuronide groups to the bilirubin to form bilirubin glucuronide, which is excreted into the bile canaliculi, which is taken by the bile. The excretory portion of the bilirubin glucuronide from the hepatocyte is an active process which is catalyzed by an enzyme known as MRP2. Remember this, it is an important enzyme which we will learn further. So now once the bilirubin has reached the bile, it will enter the intestine. From the intestine it will reach in the intestine it will reach the duodenum, second part of duodenum. Then it will reach the jejunum and ileum. In the ileum, colonic bacteria will act and it will dissociate majority of the bilirubin into bilirubin and glucuronide. So some amount of the bilirubin will be reuptake by the liver by enterohepatic circulation. This conjugated bilirubin taken up by the enterohepatic circulation will undergo further metabolism to form urobilinogen and will be excreted in the urine. The remaining conjugated bilirubin which has entered the ileum and acted by the colonic bacteria will undergo transformation and form stercobilinogen, which gives stool its color. Now we will learn about the classification of hyperbilirubinemia. The hyperbilirubinemia can be of three types: indirect hyperbilirubinemia, mixed, and direct. Indirect hyperbilirubinemia is said when the indirect bilirubin levels or the unconjugated bilirubin levels are more than 85% of the total bilirubin level. In case of mixed hyperbilirubinemia, when the direct bilirubin levels are between 15 to 50% of total bilirubin. In case of direct hyperbilirubinemia, it is defined as when the direct bilirubin levels are more than 50% of the total. Now you will have a confusion that you have heard different terms. So let me clarify that these are the latest terms and the guidelines have changed. So Indirect hyperbilirubinemia was previously known as prehepatic jaundice, and mixed hyperbilirubinemia is known as hepatic jaundice, and direct hyperbilirubinemia was known as post-hepatic jaundice. So now we will look at the differential diagnosis of jaundice, or how to diagnose jaundice clinically. So you can see hemolytic jaundice, obstructive jaundice, and hepatocellular jaundice. Hemolytic jaundice is other name of hepatic or indirect hyperbilirubinemia. Obstructive jaundice is other name of post-hepatic or conjugated or direct hyperbilirubinemia. In hepatocellular, it is mixed hyperbilirubinemia. So there is a history of pruritus only in obstructive jaundice, and there is a past history which is in hepatocellular or hepatic jaundice. There is contact with jaundice patient or drugs history or viral hepatitis infection, something like that. In obstructive, it may be stones or pain in the right upper cardiac region, etc. So now we will understand in case of past history of hemolysis, there will be history of drugs, blood transfusion, or previous congenital any abnormalities. Now we will look at the examination. In case of hepatic jaundice, the liver may be tender, spleen may be enlarged, gallbladder is usually not palpable, and pallor is absent. In case of obstructive jaundice, the liver and spleen is not tender, spleen is not enlarged, gallbladder can be palpable if there is a neoplasm, and a pallor is present, but it is not generally seen as the practical reactions. In hemolytic anemia, because of there is destruction of RBC, pallor is present. The spleen is enlarged because there is extravascular hemolysis. Now we'll look at the investigations. Urine bilirubin level are increased in case of hepatic jaundice. Urobilinogen levels are increased. Stool cercobilinogen are present, and peripheral smears show leukopenia and infective hepatitis. In case of obstructive jaundice, urine bilirubin is present, urobilinogen is absent, stool cercobilinogen is absent, peripheral smear shows is normal. In hemolytic anemia, there is a urine bilirubin level is normal or absent, urobilinogen is present, cercobilinogen is present, peripheral smear shows reticulocytes and spherocytosis. To understand it further, we will look at this like in obstructive jaundice, there is an increase in the conjugated bilirubin, right? So conjugated bilirubin is increased, and there is obstruction in the pathway of intestine or at the level of gallbladder duct, cystic duct, or something like that. So conjugated bilirubin will escape from the hepatocytes and will reach in the urine. So urine bilirubin level will be more. Since the conjugated bilirubin is not able to reach the ileum or where the colonic bacteria is acting, the cercobilinogen and urobilinogen will be low, right? So in case of hemolytic anemia, there is increased destruction of RBC. There is a conjugation mechanism is normal. So urine bilirubin, there will be no bilirubin because unconjugated bilirubin is more. Unconjugated bilirubin is water insoluble. So urine bilirubin will be absent. But in case of stercobilinogen and urobilinogen, it will be more or increased. Then we will look at the LFT functions. Bilirubin is present in all. Alkaline phosphatase is raised mainly in the obstructive jaundice. Then SGPT, SGOT will be markedly rise in the liver because it is mainly the liver marker. Alkaline phosphatase is more in obstructive jaundice because it is present in bile canaliculi. So now we will look at the jaundice classification or how to diagnose it based on the clinical symptoms of the patient. In newborn, if there is elevated unconjugated bilirubin, we will look at the intermittent episode, whether it is intermittent and episodic. It is generally due to Gilbert syndrome, which is a congenital abnormality in UDP glucuronidase transferase. It is generally predisposed by stress or any infection. If the elevated unconjugated bilirubin is mild, then it can be physiological jaundice or drugs. In case of it is severe, then it can be RS incompatibility or curricular nausea type 1 or type 2. In case of elevated conjugated bilirubin in newborn, it may be due to biliary atresia. In case of childhood, and there is a childhood jaundice and there is an anemia and family history, there will be maybe chances of thalassemia major or hemolytic anemia. In case of adult, it can be further classified without splenomegaly, with splenomegaly. With splenomegaly, it can be conjugated bilirubin can be twice or unconjugated bilirubin. In case of conjugated bilirubin, it is a cirrhosis, and unconjugated bilirubin, it is most generally a hemolytic anemia. In case of without splenomegaly, if the constitutional symptoms like fever, myalgia, arthralgia or something like that is present, or previous history of any food intake or this, then you can suspect a viral hepatitis, more generally hepatitis A and E in case of food intake, and B, C and D in case of blood transfusion or any other IV route. Then in case of abdominal pain, weight loss, enlarged gallbladder, you can look for bile stones and pancreatic carcinoma. There is a major symptoms that this slide I have forgot to mention. It is pruritus. Pruritus is generally seen in obstructive jaundice, and it is due to deposition of bilirubin in the skin. Then we will look at some of the causes of the indirect hyperbilirubinemia. The causes of indirect hyperbilirubinemia are hemolysis, in which there is an intracorpuscular defect, which may be due to enzyme deficiency like G6PD deficiency, pyruvate kinase deficiency. In case of hemoglobinopathies like sickle cell anemia, thalassemia, and can be paroxysmal nocturnal hemoglobinuria. In extracorpuscular defect, it may be due to infections like malaria, babesiosis, drugs like D-penicillamine, alpha-methyl dopa, etc. In case of physical agents like burns or any electric shock, immunological responses can also be there, like immunity destruction of RBCs, AIHA, hot and cold. Uremia can also predispose to hemolytic anemia. Some congenital abnormalities are Gilbert and Crigler-Najjar syndrome. Now we will look something about Gilbert and Crigler-Najjar syndrome. These both are due to UDP glucuronidase transferase deficiency or defect. Crigler-Najjar is a severe form which requires in Crigler-Najjar type 1 it is very severe and there is a high chances of infant mortality. Crigler-Najjar type 2 can be seen in adults. Gilbert syndrome is kind of a mild unconjugated bilirubinemia, because in this there is a mild increase in unconjugated bilirubin, and which occurs most generally in case of stress or infections. Now we look at the causes of mixed hyperbilirubinemia. It is due to infections like viral hepatitis, leptospirosis, septicemia, malaria, typhoid. In case of cirrhosis of liver, which includes many causes like NASH, alcoholic fatty liver disease, hemochromatosis, Wilson disease, etc. You name it. Then congenital abnormality like Dubin-Johnson and Rotor syndrome is also there. Basically, every etiology which will affect hepatocytes can cause a mixed hyperbilirubinemia. Now we look at the Dubin-Johnson and Rotor syndrome. This is a bit of complicated, so you have to understand it a little bit slowly. You have learned that the bilirubin diglucuronide exits from hepatocyte by MRP2 protein. So if there is a defect in MRP2 protein, bilirubin cannot be excreted from hepatocytes. And since the bilirubin is conjugated bilirubin, it is known as Dubin-Johnson syndrome, in which there is a defect in the MRP2. Now there is a phenomenon known as bilirubin hopping. Bilirubin hopping is seen when there is a excessive bilirubin and hepatocytes are and bilirubin jumps from one hepatocyte to another. The exit point from from one hepatocyte is MRP3, and the entry point to other is OATP B1 and B2. If there is a defect in OATP B1 and B2, the hepatocyte, the bilirubin, conjugated bilirubin cannot enter the next hepatocyte, so it will escape into the blood. This defect in OATP B1 and B3 is known as Rotor syndrome. Now we will look at the causes through direct hyperbilirubinemia. It includes gallstones, strictures, parasitic infections like clonarchis, etc. Neoplastic like carcinoma of head of pancreas, ampullary carcinoma of Vater, etc. Congenital abnormalities like biliary atresia. Now the main part that you have been waited, how to check for jaundice clinically. Jaundice is most commonly checked in the upper bulbar conjunctiva. In some colleges they may use the term sclera, but in majority of colleges they use upper bulbar conjunctiva. Do keep in mind that you have to perform the test in both the eyes simultaneously. In this, we ask the patient to look down, then we have to lift the upper eyelid like it is shown in this image. You can appreciate the yellowish discoloration of skin very easily. Then the other sites that can be used to detect bilirubin is a base of the tongue, then is other are nails and palms. In palms we have to look at the creases of the palms and compare it with the with the skin near the wrist. It will be more prominent in case of hyperbilirubinemia. In case of pediatric patient or you have a pediatric viva, we have to press against the bony prominences like sternum for about 3 seconds and then release the thumb. After removing the thumb, you can visualize the yellowish discoloration. Now we will learn about the common viva questions that can be asked to you. You can be asked to demonstrate the presence of jaundice. You can ask the normal values of bilirubin. You may be asked about the pathway of the bilirubin synthesis and its metabolism. You can be asked about definition of the jaundice, classification and causes of jaundice. How can you practically classify the jaundice based on the stool, urobilinogen levels, cercobilinogen levels, etc. In case of pediatric viva, you can ask about Kramer score. You should look at the Kramer chart, which is given in the Piyush Gupta, which is a great book. So that's it from my side. Thank you very much for learning it patiently, and I hope you have understand something. Please share and subscribe to this channel. Share to its friends so that more people can learn about it. Thank you.